Hello, everybody, and welcome to today's Public Health Chat. My name is René Najera. I am the Director of Public Health at the College of Physicians of Philadelphia, and I'm also the editor of the History of Vaccines project there. I have with me Deanna Najera. Full disclosure, she is my partner in crime, my wife. Deanna is a physician assistant, and she is going to talk to us about the role of physician assistants within the overall public health structure. So let me just start off by saying that public health, according to CDC, is the science of protecting and improving the health of people and their communities. So it's more than just medicine. It's a wide range of fields that come together to perform this public health action and keep the health of populations and communities healthy. And so today we're going to talk about the role of physician assistants. So Deanna, hi.
Thanks so much for having me. You had your choice in picking PAs, and I'm so honored that you chose me for this endeavor.
Great to have you on. So let's just start off with an introduction to physician assistants. What is a physician assistant, and tell us all about that.
Sure, great. Yeah. So, to be fair, the physician assistant or PA profession has been around since the mid 1960s. So we were actually based out of the idea of PA was out of World War II. So in World War II, they had a shortage of physicians with people being deployed overseas. And so they had this idea to fast track physician education. So normally medical school is 4 years of college, 4 years of medical school, and then 3 years of residency or specialty training. And they said, we need doctors now. We can't wait 7 years to go through medical school and residency training. We need people on the front lines. And so they kind of took out what they felt was extraneous and sort of shortened medical school and shortened their residency and did more on the job training. And there was a physician, Eugene Stead, who thought, this is actually kind of a good idea, that there's a lot of things, that can be said for having these individuals who don't necessarily have as much experience in certain avenues, but are very well educated. And so he was working at Duke University, and he actually thought of creating basically a permanent profession that was sort of based on this fast track model. And so he approached some military combat medics who had been out of Vietnam. The tricky part with the military is you can have some copious experience, but it doesn't always translate to one specific role in the civilian world. So you're, doing all these advanced procedures to save lives on the battlefield, and then you come back and you're not really a paramedic, you're not really a nurse, you're not really a doctor, and there wasn't really a spot for them. And so he basically condensed medical school and condensed residency and made it into the PA profession. And so there were several titles originally. So it was physicians with an apostrophe S assistant initially. There was also what were called medics or medical extenders, and then physician associates. And so over time, we sort of made our name into physician assistant, but we realized that that name is a little bit sort of constricting because it's not just what we do. We don't just assist physicians. We see patients on our own. We are involved in a lot of different aspects of patient care. And so just as of a couple of years ago, we've made the decision as a profession to change our title to physician associate. So it's still the same acronym of PA, but you may hear those terms sort of viewed interchangeably. So throughout this, I'll just say PA to keep it simple, but you may see physician associate or physician assistant depending on where you work. So our education, we graduate from college in a variety of different backgrounds. And then the majority of PAs have 1 to 2 years of direct patient care experience, working as medical assistants, paramedics in nursing homes and hospitals and office practices, sometimes in research and things like that. Then we do a full year of didactics or classroom training. And that's Monday through Friday, 8 to 5, 8 to 8, sometimes on Saturdays, where we learn all of the really foundational information on medicine. And then we have a year of rotations. And this is where we, again, follow the medical model. We follow the physician training model in that we have rotations in a variety of specialties. So general surgery, orthopedics, women's health, primary care, which includes family practice, as well as pediatrics and behavioral health. And then depending on the program you go to, you may have electives and things as varied as burn or trauma or a NICU or international and things of that nature. And then when we graduate, we work as part of a collaborative healthcare team. We're working with physicians and nurse practitioners to take care of the patient in every sort of medical setting. So that's, a lot of talking for just to kind of give you an overview of what we do. Personally, I started in family practice and then transitioned to urgent care and then transitioned to emergency medicine. And with my role in emergency medicine, I sort of had even more involvement in community health and public health and got to know our local health department. And this is right before COVID hit. And then when COVID did hit, I ended up working almost full time with the health department through the initial stages of the COVID pandemic before transitioning. And now I'm part-time in the health department and part-time in emergency department with a sprinkle of psych on the side, just because I need more things to do. It's the joy of being a PA is that I can do those kinds of things.
Yeah, so the U.S. public health system is very physician centered, right? And obviously, physicians are at the center of the healthcare system. And so they're also taking a leading role in public health, leading health departments, leading health organizations, agencies, et cetera. You often don't see somebody without an MD or DO after the name being the head of a public health organization. But having said that, we see this expansion into different members of the healthcare team also contributing to public health. So you talked a little bit about working during the pandemic with a local health department. Can you talk a little bit more about the kind of work that you did during the pandemic with the local health department, and then now in the recovery phase, non-pandemic related work within public health?
Absolutely. So this again gets to that broader conversation of how public health has changed over the years. It used to be much more clinically based. So you'd have clinics, you'd have a kids clinic or a pregnant women's clinic, or, different outreach where you did actual physical care. But because of reduced funding and streamlining and healthcare systems and a whole bunch of other conversations about the pros and cons of how that has turned out, but you don't see as many health departments doing direct patient care except for very small populations. And so what has happened is you'll often have one or two physicians that are your health officers or your deputy health officers that sort of direct overall care or make some higher level medical decision making, but it's your nurses and your community health workers, your environmental health specialists, your behavioral health specialists that are doing outreach efforts. So still doing patient care in the sense of coordinating services, case management, connecting, following up for individuals, but not necessarily doing like medicine administration or changing bandages. It's not saying that they don't, but they don't usually. They're more coordinating care. So when COVID hit, we did not have a lot of actual clinicians that could sign orders, could sign prescriptions, could make medical decisions, or could direct nurses on how they could sort of do things. And also the other thing is that a lot of people in public health have been in public health for a long time. And so they hadn't done bedside medicine in a while. And so because of my background and training, I was able to help assist with doing a lot of things as far as developing some protocols and policies. But I also did a lot of outreach. So the health officer and I went out to a nursing home, which was one of the first outbreaks in Maryland. And we actually did a walkthrough to talk about how they could cohort patients and try and keep their patients safe. I worked a lot with our law enforcement agency to keep both the officers as well as the individuals who were in the detention center safe. We did outbreak investigation, and sort of assisting with, again, not just the outbreak itself, but how do we sort of stop this from blowing up in the community, doing different interventions, and also messaging, what kind of messages are going to hit different kinds of populations, and sort of weighing in on that a little bit, and sort of saying, of course, early in the pandemic, what was true medical advice? How can we grade the evidence, and what is the evidence actually saying, as well as just sort of best practice or best intentions, and sort of figuring out what was a good message that we could put forward. So that's what I did initially. As we transitioned into, post-pandemic, I guess we can say, sure. So my original hiring role was within our reproductive health or family planning clinic, which is a Title X clinic. So that's a federally funded clinic where the federal government gives the money to the state, and then the state distributes it to the county. And so I work partly with them doing direct client services regarding STD, contraception, pap smears, breast cancer awareness and screening and that sort of thing. But then I also, again, help with our nursing competencies and developing best practices and policies, and just also, again, a resource for the health department. When somebody says, hey, we have a patient or a situation that needs kind of a clinical insight, can you weigh in on that? And if I don't know, I know who to go to and how to ask those questions. And that's one of the best parts about being a PA is we always work as part of a team. So I know what I don't know, and I know where to go to ask for help. And I feel very confident and comfortable in saying, like, great question, I'll have to get back to you on that. And that's a lot of what I do on a regular basis.
So you talk about your career in emergency medicine and then the work at the health department. Can you give us other examples of other PAs or PA-led initiatives within public health that you know of?
Yeah. So, it doesn't always have to be just working at a health department. And I think that's what, in medicine in general, we do a lot of things under this umbrella of medicine, but is actually often community health or population health. So how I got even in with the health department is I was in the emergency department. We were seeing huge rates of opioid related deaths or opioid overdoses. And we were working on a community level to try and figure out what interventions we needed. And so it was the people coming to the emergency department that had already overdosed or were seeking help from addiction issues. And we were trying to figure out better community wraparound services. And that's where we started having conversations. They needed data. They needed to know, when were people coming? What were they coming in with? What were those complaints? And then we worked to have peer support services embedded in our emergency department. And I was able to be the liaison between the clinicians and the providers and these peer support individuals who were from our social work, case management, management department with our health department support. And so that's, one way that you can be involved in that. Another way that you can be involved in sort of these community interventions. So there's like the child fatality review committees or the fetal infant mortality reviews or local overdose fatality reviews, where basically any death that happens within the county is sort of examined from a different standpoint involving all these interagency community groups that sort of say, how could other interventions possibly have stopped this death from occurring?
Mm-hmm.
But also sexual assault response teams, domestic violence teams, all these kinds of things. They, again, are multi-agency. So law enforcement, even housing support, child protective services, the juvenile justice and criminal justice systems, as well as the health department. They often sometimes need a clinician to say like, oh, well, these medications seem appropriate, or these medications were not appropriate, or this is a normal prescribing habit or not a normal prescribing habit. They just need somebody to kind of sometimes run things past. And that's where, as a clinician, as a PA, an NP, as a physician, having that sort of viewpoint can really be beneficial on a community or population health level of having this influence out, not just being the recipient of people that are already struggling.
So we've seen the headlines, right, of the shortage in physicians, the shortage that is already here when it comes to care. How do PAs fill that gap?
So originally, the whole foundation of the PA profession, as well as nurse practitioners to extent, was to fill that gap. Physician shortages are not a new thing. It's kind of like the sky is falling. It's constantly falling. And we just sort of manage to just barely stay steady. And so, PAs can work in every single specialty. You've probably interacted with a PA, whether you know it or not, in every setting. And so we help, again, extend and we support, but we also manage our own patients depending on the type of specialty that you're working in. So, sometimes this might be with regards like an operation, like your initial evaluation or post-operative care. The PA is doing that to free up the physician to be able to do a surgery or do something else. Or in primary care, it may be your primary care physician is actually a PA or an NP, where they are the person taking care of everything that you need from what we say cradle to grave. So from birth to death, a PA or NP or a physician can be taking care of you. So again, it's trying to get people access to services, to a clinician that's competent, a physician that practices evidence-based medicine, that provides them the care for the whole person. And PAs are primed to be able to do that.
Yeah, and during the pandemic, we saw the expansion of telehealth services, right? And so a lot of those folks doing a lot of those services were PAs and NPs, and a phenomenal explosion of that. What are some of the legal hurdles to these expansion of services?
Certainly, yeah. So telehealth pre-COVID, we thought this was going to be huge. This was going to really improve access to care. This was going to be sort of the fix for a lot of the healthcare shortages. Because if we had people that were sitting in an office somewhere could now reach across the state, across the county, and provide care to the individuals that couldn't get to the office, especially for some specialty services that are more lab-based or things like that, where you didn't necessarily need a physical exam, but you needed to talk to somebody or do these case consultations. Unfortunately, what COVID showed is that while it is great and it does allow that access, it doesn't necessarily eliminate barriers. You have to have a smartphone or a computer or something to access an internet service. Every practice has its own platform that they're using, and they're not always intuitive. Sometimes you have to download something or you have to have special permissions because we have to balance this privacy versus access component. And then anybody with a language barrier, it was very hard to get kind of group calls where you had an interpreter, a clinician, and a patient on the same call because they're supposed to be secure where it's just one-to-one communication. So the individuals that already didn't have access are still struggling to have access to providers, even with telehealth being present. Now, having said that, additionally, PAs and NPs often have very differing rules state to state, depending on how we're allowed to practice. In Maryland, I may be able to prescribe certain medications or deal with certain patients or patient complaints or different kinds of issues with that. But then I move to a state just across the line, and suddenly my ability to do certain things can be better or can be worse. And then what we're still struggling with is the patient's physical location, the provider's physical location. But what if we both reside in Maryland, but the clinic office is in Pennsylvania? So they're Pennsylvania clinic based, but we're Maryland physically based. Like, how do you manage that? And unfortunately, that's still a work in progress. Nobody has those answers. And that's where we look for, like the Federal State Medical Board Association has talked about an interstate license compact. So nurses are already able to do that, meaning if I'm licensed in one state, it's recognized in other states. And they're starting to push that forward for physicians and PAs. So we're really, really hopeful that states will adopt that because it does streamline things. It makes it easier for patients to access care, and especially important in the telehealth world.
Where do you see your profession within medicine and within public health in the next 5, 10, 15 years?
where do I see medicine in general? I mean, the amount of changes that we've had in the last 5 years, it's really hard to tell. There's been calls for universal health care for a number of years. And we saw with the COVID pandemic that the disparities in care have just worsened. They're not getting better. And they haven't been getting better for decades. This isn't just a COVID thing. COVID just sort of shined a flashlight on a lot of issues that have been existing for a long time. So I think that, medicine in general is undergoing a bit of a revolution. There has been a lot more attention paid to the wellness of providers. For so long as providers, as clinicians, and we were told to just suck it up. This is the world of medicine. And we've been seeing some gradual changes with that over time, but now we're asking for more, and we're saying that we need time off. We need to have better boundaries. We need this work-life balance that everybody's looking for. Yeah. Has not existed in medicine probably ever. And that's something that we need to really address to keep our workforce healthy, because I can't take care of patients if I'm not taking care of myself. And so what that looks like is challenging. And then you have all these extra aspects of, Surprise Billing Act, and you have the telehealth bills, and you have all these other sorts of components. And the thing is, worldwide, nobody has it figured out. There is no perfect healthcare system. All of them have their pros and cons, but the US healthcare system has been struggling for a while. We're cutting edge in a lot of ways, and yet we have some of the worst maternal health outcomes. We have some of the highest child fatality rates, some of the worst health outcomes for other chronic diseases that are preventable or able to be controlled. Look at the rising rates of syphilis and STDs, in other countries that's never seen. Our vaccine rates are dropping. There's a lot of different things that we're not doing a good job of, and we need to pay attention to, but that requires money and time and clinicians. And hopefully PAs will be considered part of the solution. I mean, we've been part of the healthcare landscape for over 50 years. We're not going anywhere. And hopefully people will continue to embrace us and the care that we can provide our patients, because we are part of the team approach to healthcare. That has always been our goal. And that's not going to change whether you call us physician assistants, physician associates, medical extenders. We are still here for the patients, and we're going to continue to be there.
Good. And if somebody wants to join you and become a PA, where do they start and what do they have to look forward to?
Sure, absolutely. Well, it's a trying path. It's harder to get into PA school than medical school right now because of the number of applicants for a limited number of seats. And PA school is in person. You can't, work and have a part-time job while you go to PA school. It's 2 to 3 years that you have to take off and dedicate to your education, but it is an extremely rewarding career. And we really hope to see an influx of, really inspired people that, have seen what COVID can do and are still willing to join the ranks and join us in taking care of their communities. So AAPA.org is the American Academy of Physician Associates, our national organization, and they have a pre-PA section. And every state and territory has their own PA society. All of the military branches, we have a very strong relationship with the military. They all have their own organizations as well. And again, you've probably met a PA, so just ask them, ask them about their career, ask them what they like about it, what they don't like about it, and see if it fits for you. There's lots of mentors out there that are willing to just even talk over a cup of coffee or something like that about what it's like to be a PA and see if that's a good fit for you.
Great. So thank you so much, Deanna, for joining me on this public health chat. I want to remind everybody we'll be having these chats in the future as part of our ongoing conversation about public health from the College of Physicians of Philadelphia. I invite you to visit our website at collegeofphysicians.org. We are located downtown Philadelphia. You can drop by and take a look at the very nice old building, historical building there. Visit the Motor Museum anytime within the hours of the museum, obviously. But thank you so much, Deanna, for being here. Thank you for talking to us about PAs and their role within the medicine and public health, which is changing. And the pandemic has certainly, like you said, changed a lot of things. So we'll see what is coming down the pike. So thank you again. And thank you everybody for listening.
Thank you.